Good evening. I'm your host, Arlana Shikongo, and tonight on Heartbeat, we'll explore how vaccination rollout plans are implemented and what needs to be considered when deciding who and how to vaccinate. Joining us via Zoom this evening from London, we have Olivia Boyd, who is an epidemiologist and infectious disease modeler with expertise in using genetic data for outbreak analysis, health surveillance, and pandemic responses. She's worked in the SARS-CoV-2 phylogenetics response team at Imperial College London in adjunct with the Covid-19 Genomics UK Consortium to estimate the size of the Covid-19 pandemic using viral genome sequences. She's also developed a first-of-its-kind SARS-CoV-2 variant scanning system to identify and monitor emerging variants of concern for Public Health England as part of the UK pandemic response. So, her expertise will help us get a grip on understanding what goes into a vaccination rollout plan, as well as some more insight into COVID-19 variants. Olivia, thank you so much for joining us this evening.
Thanks for having me. Happy to be here.
I'm happy to have you too. And to get right into it, you have so much experience in terms of COVID-19 variants, rollout plans, and just responding to a pandemic. So to get us started, if you can just talk us through how a vaccination rollout plan is established and what factors need to be considered when putting one together.
Yeah, absolutely. So I think the first thing we have to think about when we, think about rolling out a vaccine is efficacy versus equity. Mm-hmm. So oftentimes there is a big trade-off between getting the vaccine out as quickly as possible and to, whoever is there and ready to receive a vaccination mm-hmm. versus actually ensuring that we're getting it to the people that are most immunocompromised or most at risk for the disease that we're dealing with. And so, for example, with SARS-CoV-2, we can imagine that actually it's really important that we think about age distribution in the population. So, when you're dealing with countries that have very large young population and smaller older population, it's good to target the old population first, because this way we can decrease severe cases in the population and also decrease number of deaths that are occurring. The same thing for immunocompromised people when we have a lot of them in our population. And this is kind of the primary focus. I think another thing we have to consider is what kind of vaccines we're receiving when we're rolling out. Because as you might know, there are quite a few options now. We have single dose versus double dose, mRNA, whole genome vaccine. And when we're thinking about the rollout, we have to consider, are we going to need to double dose people? In this case, should we target first dosing as many people first? And this, again, depends as well on when we will receive the vaccines. Mm-hmm. Because if we receive a small amount, but we don't really receive another shipment for a long time, ideally, in this case, you might want to give people first doses first, as many as possible, and then we will give second doses once we receive them later. Mm-hmm. So as you can see, there's quite a few variables that come into play when you're thinking about the rollout.
Absolutely. Now, it's not the first time that on a global scale we've had to roll out vaccines. We've had to do it with, yellow fever, the little dripples that we used to get in school, a vaccine that we didn't even know we were getting. We were just kind of signed up for that through our parentals. But if you can maybe just talk us through how a vaccine rollout usually works, and then maybe draw some comparisons to previous vaccine drives that you know of.
So generally what happens is usually you first have to identify when you'll be receiving the vaccine shipment, what quantity you will receive. And so I think, for example, we look at the Gavi project and everything they're doing with vaccine, spreading vaccine, trying to spread vaccine access on a global scale. And so what Gavi does, for example, is they intake vaccines and they try to, as equitably as possible, allocate vaccinations to different countries around the world. The next thing we have to consider is how long it will take to produce the next round of vaccines. And in that time period, we have to think about, okay, who can we vaccinate now and what sort of time period do we have to wait before we can get the next round? And you can see this, for example, in the UK, when we received our first round of vaccines in December and January, we decided that we would delay allowing people to receive second dose to ensure that as many people as possible could receive their first dose of the vaccine. And this actually turned out to not be detrimental, because at origin, when the vaccines were first developed, they had said, okay, we should do first dose to second dose within 3 weeks. But actually, there's been lots of recent developments that supports having a delay to allow someone to develop more antibody from their first dose, and then having a booster second dose at a later time point. And so what's quite interesting is actually, as part of the rollout here, we identified there's actually a potential positive of delaying slightly when we give our second dose of vaccination. But these are all sort of things that go into designing the rollout itself. And I think a big priority is, especially when you're dealing with a pandemic, you don't often know when you're going to be receiving your next batch of vaccines. And actually, this can, you might be told you're going to receive them, and then something happens, there's a bad batch, we don't know. And so you have to be quite flexible to this response. And I think this is where we consider as well whether we have lockdowns in place, non-pharmaceutical interventions such as social distancing, wearing masks, and how that can be balanced with how we roll out the vaccine as well.
Absolutely. And you mentioned that based on what the UK has been able to, see and experience, that there were actually potential benefits of delaying the first dose to the second dose for, the 2-dose vaccinations, which I think is really interesting, because in Namibia, we had an issue when our initial consignment of vaccines ran out, where a lot of people who had gotten their first dose were very fearful about what would happen if they didn't get their second dose in time. So maybe if you could just talk a little bit about, how this extra delay between the vaccines has proven to potentially have benefits, because as you mentioned, there's more time for the body to develop antibodies, right?
Yeah, absolutely. So, when you receive a vaccine, basically what happens is, whatever vaccine you have, either a non-living, essentially, version of the virus, or an mRNA vaccine, which is a smaller portion of the genome, your body intakes this, and the vaccine enters your cells, and your body replicates basically a little version of it that then your antibodies can learn to recognize. And so basically what you're doing is you're training your immune response to be activated when you actually encounter the virus of interest in the future. And so you can imagine, if you wait a little longer, actually, what happens is your immune response will grow a bit. So you can actually allow yourself to develop more and more and more antibody that you're then storing for when you actually encounter the virus in the future. And so I think it's still not quite clear, because, of course, we're still actually quite in the early stages of the outbreak. And a lot of the research we're doing is, in real time as we go along. But what you can imagine is, what we are seeing is that actually there's relatively similar antibody response if you receive at 5 weeks your second dose after your first dose, or at 8 weeks. So actually, the timing does not seem to be as important. And depending on the study, some studies find that actually a bit longer might actually provide a slightly stronger antibody response. Because then once you have, you're sort of reaching a peak point with your antibody, and then you're boosted again with the second dose, this allows you to even elevate even more your antibody response.
Absolutely. Thank you for explaining that. I think that's going to be very reassuring to a lot of our audience.
Yeah, absolutely.
And you also mentioned, identifying specific groups at the initial phase of the vaccine rollout plan. And you mentioned, of course, the immunocompromised, the elderly people. If you can maybe talk us through why it's important to focus on certain groups first, and how that helps with what we're going to come to eventually in discussing herd immunity.
Absolutely. So I think when we think about, protecting a population, that's and when I say population, I mean a totally susceptible population. So a population that has no baseline immunity to a new virus that's been introduced into the population. We have to consider who is most likely to be at risk for this virus in terms of severe disease and in terms of potential death as a result of the virus, death attributed to Covid-19 disease. And I think when we're thinking about this, for example, we can look at influenza. or measles or other diseases that often actually impact children a lot more. So, in this case, we often decide we have to vaccinate children first because this is the most at-risk population in these cases. And oftentimes as well, what you see in viral diseases in particular is this U distribution, where you have basically children and elderly people that are at most risk because they don't have any long-standing immunity in some sense to this type of virus. In children at least, and then in elderly people because their immune response is obviously weakened in comparison to sort of younger and middle-aged people. What's really interesting with SARS-CoV-2 is that actually children do not seem to be as impacted, which has actually been, I think, a blessing in this whole pandemic, because I think the response and the outbreak would have been very, very different if we had seen a similar level of children having severe disease and passing away. It's already been, of course, as we all know, quite terrible. But I mean, imagine the alternate reality.
Yeah.
And so I think, in this respect, when we think about approaching vaccinating a population and how we want to sort of subdue the outbreak, the first thing we should consider is how do we save the people, or how do we keep people from having severe case or from dying of COVID? And this means targeting people who are at higher risk for severe disease, such as elderly or immunocompromised people.
Absolutely. And I know that with Namibia's vaccination rollout plan initially, they had identified certain groups, people with various comorbidities to be at the front of the line for receiving the vaccine. However, in Namibia, there's also been a lot of vaccine hesitancy. So the second phase of that, once they'd seen that these identified groups were not coming in numbers anymore, they opened up the vaccines to the entire population. And at that point, literally anybody who wanted to be vaccinated could go get vaccinated. And that's still the case. So I wanted to ask you, is this free-for-all approach to vaccinating, considering that there is quite a high level of hesitancy in the nation, is this approach relevant? Is it the best way to go about it, considering the hesitancy?
So I do think, there is a point where we have to, move on from trying to say, okay, we vaccinate old people and immunosuppressed first. And as you said, if there is vaccination hesitancy, we have to accept that some people are not comfortable. They might not understand the science very well, or they might, it's quite understandable. There's also a lot of misconceptions that circulate now about, for example, mRNA vaccines. It's a new technology, and I think a lot of people are very worried about receiving this. As an infectious disease modeler and epidemiologist, I think mRNA vaccines are amazing to me because it's a vaccine you can create very quickly. It's actually very effective. It only requires a tiny part of the genome. And so it can work on lots of different variants. It's more likely to work with lots of different variants. But to get back to the free-for-all sort of approach, I mean, you see this happening in European countries as well, where they did a sort of scale out up to a certain age point, and then below that age point, it was a free-for-all. And I think that's not necessarily a bad thing. I mean, you look at the UK, we did a very, very tiered scale out where we said, okay, we're going to start with 80-year-olds and then 70 and then et cetera, et cetera. And even once we reached 40 years old, we went by 2-year age groups. So 38, 36, 34.
Oh, wow.
Which I think is a little ridiculous, personally. But, the point here to say that actually by doing this, what the UK did create is, these sort of social pockets, actually, that had unvaccinated individuals that were highly likely to be, socializing with each other. For example, age 20 to 24, people that are going out, that are, having lots of unprotected sex and, dating and everything else. And, very active in their social lives, we left this pocket sort of unvaccinated. And you can see this reflected, I think, slightly in now the Delta variant takeoff we've had here, as we've fully reopened, but also allowed the variant to sort of take off in the population. So I think there is a trade-off, but, I don't think it's necessarily a bad thing to let it be a free-for-all, particularly when you have a low vaccine uptake or vaccine hesitancy. And you're still sort of trying to get vaccinations to be regulated throughout the population.
Absolutely. And you mentioned, this pocket, the 20s, 30s age group that is more social. And that made my mind go to this idea of herd immunity, which is something we constantly talk about. I think we've also had a little bit of a discussion on previous episodes of the show about herd immunity. But if you can just talk us through what herd immunity is and why it's important to achieve that in the course of a pandemic.
Yeah, so absolutely. The idea of herd immunity is that you reach an immunity threshold in your population where the virus can no longer spread through the population. So if you've probably heard of this R, the reproduction number, many times now since the start of the pandemic, right? And so this idea is that we reduce the reproduction number to below 1. So essentially we say for every case, we have less than 1 new case to follow. So really, the idea of herd immunity is that we eliminate transmission. We stop the virus from continuously spreading in the population. And you can think about this in the context of multiple different diseases, right? For measles, I think herd immunity is about 95% because it's a very transmittable disease. So you really have to have a very, very high level of vaccination in the population to allow this to not spread in your population. Polio, it's about 80%. We actually don't really know what it is for SARS-CoV-2 yet. And there's a lot of speculation around this number. But the one thing we do know is that the more we vaccinate, the less likely the virus will transmit in the population and the safer we will all be. And that's really the goal now is can we get on a global scale to a level of herd immunity? There is also, of course, the problem of new variants being introduced.
Yeah.
And actually what happens with variants is when we introduce variants, they have variation in how quickly they transmit or their transmission rate. And as a result, you can imagine this essentially actually causes the herd immunity sort of goalpost to move around a bit, depending on which variants you have circulating. Because, for example, if you have Delta variant, you need a slightly higher level of vaccination to attain herd immunity than if perhaps you had a previous variant in your population that was less transmittable.
And then in the circumstance, for example, talking about the high level of hesitancy, what would happen in a circumstance where more than half the population says no to being vaccinated?
So, we see this in a few countries already, and it's quite concerning because actually what you can imagine is that we have a virus that transmits very efficiently. And when you are not attaining herd immunity, you're allowing this virus to continuously transmit in your population. And what that means is that you're allowing your virus to continuously mutate and evolve. And as we, the lower that we vaccinate and the more we allow the virus to spread, and the more we allow it to replicate and increase in mutations that are in its genome, its whole genome sequence, the more likely we are to, have novel variants, new variants introduced into the population that are probably potentially more severe, potentially more infectious for children, potentially more likely to lead to death. So this is actually a very, very big concern of the scientific community in particular, and I think on a global scale as well for the future. And really, it's also an interesting converse view because I think in the Western world now, a lot of people are saying, the pandemic is over. And actually, from my perspective, we are far from over because we need to attain this on a global scale. Otherwise, we will continue to have variants that are circulating and reemerging in the population. And our vaccines may no longer work for these variants as well anymore.
Absolutely. And that makes me wonder then, you kind of already touched on this, but if we can maybe just hone in on this specific question, just briefing us on how exactly a variant arises. For example, in Namibia now, we are aware that we have the Delta variant. In the third wave, our ministry confirmed to us that, samples that were tested indicated that there was the Delta variant. We had the highest number of new infections, COVID-related deaths that we've had during this third wave than we've had through the whole pandemic. So clearly, these variants, as the experts say, more infectious, more transmissible, and more variants can pop up. So how exactly does a variant come to be?
So, really good question. basically what happens is when a virus enters a cell in your body, it uses the machinery in your cell to replicate itself. Mm-hmm. So viruses need us to replicate. That's why they infect us. That's mm-hmm. their goal in life. So when they're in the cell and they're replicating, the thing is this machinery they use in our cells to replicate themselves is often prone to error. Much like humans, our cells are also, not perfect. So what you can imagine is as you're replicating lots and lots of viruses over and over, you start to get errors within the viral genome. And what I mean by this is the nucleotide, which is what actually make up the genome, these start to change over time. Mm-hmm. And as you accumulate more and more changes in your genome, you are more likely to result in an emerging variant. Mm-hmm. And what that means is that there's been a shift in basically a mutation causing the virus to act differently. Mm-hmm. So, for example, in the Delta variant, we have a mutation that makes it so it binds it has a higher binding affinity to our cells. Okay. So it actually makes it better at transmitting. And the more that we allow the virus to spread and keep replicating and keep mutating, the more likely we will have more variants like this that emerge. And actually, as the pandemic goes on, you can get a variation in variants that mutate faster or slower. So, this is a very big concern. And that's why that's what my work focuses on, is all we do now is monitor novel variants as they emerge and mm-hmm. keep watching them as they go on to make sure they're not like another Delta, hopefully.
Absolutely. And you kind of already actually touched on this question, but you made that connection between the spread of the virus, the spread of variants, and being too populated in an area, mass gatherings, for example. Because as we know, one of the approaches that all countries have had is to try to minimize and diminish the way in which people are gathering, so that there isn't this, mass congregation, which would then lead to the further spread of the virus. And then just on that note, we kind of had a little bit of an explanation last week as well on how congregating in groups, mass gatherings, affects the further spread of the virus. You touched on it a little bit, but can you just go a little bit more in depth, for example, to explain how when you as an individual pick up the virus from somebody, how it could be that your body is the vessel in which the virus is now starting to mutate, and then how this begins to bounce around and essentially spread variants?
Yeah, absolutely. So basically, when we think about mutations, we can think about them in a generation. Mm-hmm. So what I mean by a generation is basically a time from when one person is infected to the next person. And so this is how we start to accumulate these mutations, right? Mm-hmm. We get the virus jumping from, let's say, me to you, and maybe in that time, there's a mutation that's occurred. And what you can imagine is then when you have this occurring in a mass gathering, we have what we call super spreading events occurring, which actually are oftentimes how, these types of variants can really take off. So, for example, you could have, a group attending a concert or, a religious congregation, things like this, where you have lots of people in one place. And you can imagine that one person could show up who's infected with this variant, and all of a sudden, and it's a highly transmittable variant, and all of a sudden, we've had a super spreading event where potentially, 30, 100, 200 people have been exposed, and then can onwards pass this variant itself. So as you can imagine, this is why, oftentimes one of the first non-pharmaceutical interventions we use to try to control these sort of scenarios is to limit large gatherings.
Yeah. Absolutely. And in regards to the variants, I know that there are two categorizations. There are variants of concern, and then there are variants of interest. What is the difference between the two?
Yeah, great question. So basically, variants of concern are variants that have been deemed to have higher transmission or higher severity, or other factors of interest. And so these are variants that have confirmed mutations that actually can lead to causing this. Variants of interest, or variants under investigation, are variants that we are ongoing monitoring, because we think they might have mutations of interest, but they're not a variant of concern yet. They haven't shown to have necessarily higher growth rates or higher transmission compared to what's generally circulating in the population. And, so what you can imagine is when we're identifying the variants, one thing that's really difficult is that the genome sequence is, thousands of nucleotide bases long, right? There's lots of little pieces that build it up. And we're trying to identify these little segments that might have caused this thing to become more transmittable or more infectious. And so this is why when we're looking at, for example, variants of interest, we are basically trying to see, okay, are there mutations here that might be causing something? Or is there something in the way this this variant is acting that is causing it to be more transmittable?
All right. And there are a number of variants of concern that are affecting various populations at the moment. In Namibia, we currently, as far as we know, only have the Delta variant. But I know that there are others. There's the Lambda, the Beta. Can you tell us just a little bit about how each of these variations differ from the original coronavirus?
Yeah, so the original coronavirus variant, I guess we could call it, or the original genome, we call it colloquially Douglas.
Okay.
So Douglas, let's call it, and it was a relatively transmittable virus at origin. But actually what we find now with these new variants is that, as you can imagine in any type of evolution, generally evolution occurs. And it can occur in multiple ways. It can occur in a way that makes a virus less transmittable. It can occur in a way that makes a virus equally transmittable, or it can occur in a way that makes a virus more transmittable. And that's where we get these variants of concern. And so what you can imagine, is now of importance is monitoring these variants of concern, because this is what is going to continue the pandemic for us. And like you mentioned, you have Delta now. I believe Beta variant is also circulating in parts of sub-Saharan Africa and is known to be very severe, and I think actually more associated with deaths from COVID. And so, these are things of really great concern. And I think, as you mentioned, when you have regions where you have low vaccine uptake potentially, or vaccine hesitancy, and more variants potentially being introduced into the population, you really have to start thinking about how we can control the outbreak here. And that means re-implementing more non-pharmaceutical interventions, having to use things like infectious disease modeling to try and predict what the transmission will look like and when we will have to potentially lock down or not. And this is what we can use infectious disease modeling for. But ideally, what you really want is, to increase vaccine uptake and limit transmission in the population.
Yeah. And an important point, because this has been, I think, probably a salient topic all over the world, is people wondering, how can a vaccine work when there are so many variants to this virus? We have a comment here from one of our readers that I'm just going to read to you verbatim so that we can address this. He said, "Please ask how this vaccination works in a virus that keeps changing so fast." And then he makes the comment, "Africa, they will deplete your revenue." But I think the important thing here is, how does the vaccines that were produced based on the initial virus, how are these vaccines going to work against the variants?
So when we develop a vaccine, what we do is we try to choose portions of the genome that have a low likelihood of mutating. And so what I mean by that is they're stable parts of the genome. So for example, when you look at the mRNA vaccines for Pfizer and for Moderna, what these vaccines actually do is they only take a portion of the genome that represents the spike protein. And the spike protein is the protein that actually allows, I think I mentioned before, it allows the virus to bind to our cells. And so by only using the part of the genome that replicates the spike protein, our body then learns to recognize just the spike protein. And as long as you've chosen a relatively stable spike protein to replicate as your mRNA vaccine, essentially, this allows your body to be able to recognize lots of different variants, because they might have some mutations, but their general spike protein looks the same. So, you can imagine it's like having, 3 different dolls from the same company. They might have slightly different hair or slightly different dress, but actually the shape is generally the same. So the immune system can still see, that I need to capture that thing and get it out of here.
Absolutely. We have another question here, which I think your expertise will really help with. The reader asks, how can we better tackle the misconception that the existence of variants is merely a ploy by governments to enforce lockdowns once again? How can we reach those individuals who are still cynical?
Yeah, and I think, this is one of the hardest things as scientists we've had come out of the pandemic is all the misconception that comes around the outbreak and around vaccines. And, listen, I'm not a government, I'm not a government, man or whatever. But I think the real takeaway here is that being in a lockdown, I don't think is ideal for the government either. It's not good for the economy, right? It's not good for the general health of your people. It's not good for your healthcare facility. It's not good for the livelihood of the country. And I think, if all else, we can hope that people at least can try to see this side of the argument that nobody wants to be in lockdown, right? The goal of the government, I don't think, is to, control people and put them inside their houses, right? I think, the goal of the government is generally to, ensure the country is working and is economically active. And, lots of part of this mean that a lockdown is not ideal for anyone. Which again points back to, if we vaccinate more, then hopefully we can move away from lockdowns in the future, because I think probably you guys are just as sick as I am of being stuck in the house.
100%. I think we're all tired of being stuck in the house and we would like to go outside. But as you said, what this is going to depend on is the vaccine uptake. Now, I'm sure that as an epidemiologist and as an infectious disease modeler, you've heard a lot of the conspiracies. And one of the biggest ones is this idea of a microchip being planted in your body through the vaccine. On a basic level, it seems obvious. Like, obviously, there's no chip. But there are a lot of people who are very fully convinced, especially given the rate at which these vaccines were produced. A lot of people are questioning how this is possible. And for that reason, they have all these conspiracies. So just to close us off a little bit, since a lot of the comments are on that, I wish you could see them. But a lot of people are saying, we will not be forced to be vaccinated. There's one comment here that says evil vaccination. But just to close us off on this topic, if you can just talk us through a little bit the history of the vaccines, because the vaccines didn't come out of nowhere. It's building on research from the past. And then just any comment or feedback to allay fears that there is a microchip in our vaccines.
So let's let's first discuss the vaccine development. So actually, we have the whole genome sort of inactivated virus vaccine, right? Like AstraZeneca and Johnson & Johnson. And what you can imagine is these types of vaccines have been being created for a long time now. We have a lot of research that can back this type of vaccine. This is not as difficult of a vaccine to make, actually. For example, we have influenza vaccines that we administer every year, and it's the same kind of thing. Now, moving to the mRNA vaccine, actually, there has been long-standing research for, I think over 20 years now of people trying to create this type of vaccine. What the thing was before is that they were trying to create it with influenza, which is a very different virus, and actually mutates much faster than COVID, than SARS-CoV-2. So, this is the first time that actually, from an mRNA vaccine perspective, we've had a virus that, I know we hear all these variants jumping up, but actually, comparatively, it does not mutate that quickly. So you're able to find a stable region on the genome that you can create a vaccine from. The problem with influenza is that we don't have a stable region on the genome. So we can't take a small portion of the genome and create the vaccine. It's like the dolls thing I said again, right? We can easily take a piece of that the SARS-CoV-2 virus and recognize it. But with influenza, because we have so many subtypes in circulation, it's really hard to find a part of the genome that can be mimicked for all the subtypes that we have in circulation. Now to address the microchip. I think I'm not really sure where this conspiracy originated from in the first place, but all I can say is if you're really worried about a microchip, then you should probably throw your phone away, because this is the perfect microchip we have already in our hands at all times. So I don't really see why we would waste so much money putting a microchip into every vaccine. I mean, it would also be extremely expensive. And I think, people don't realize that actually, especially when we're working with third world country data, we actually have access to a lot of mobile and telecom company data. So, we have mobility data on lots of people. So if you're really scared about being tracked, throw your phone away because that's where you're being chipped. It's not in the vaccine.
Absolutely.
But yeah, that's my piece on that.
No, thank you for that, Olivia. That is very helpful. And I think just regarding, our vaccination rollout plan, we have a lot to learn from countries that are, how is it best to put this, ahead of us, in a sense, when it comes to this virus. And I know that at the moment, Namibia, with this third wave, there have 100% had to be changes to how we are implementing vaccine uptake. And of course, we had that whole incident with, we were running out of vaccines and we had to acquire more. But I do believe that at this point in time, we've acquired more. So I think we're well on the way of dealing with that. Olivia, before I let you go, I have one more just a few more comments from the audience that I'm going to take because, there's a lot going on here. There's a question here that says, if one takes the vaccine, will his or her DNA still be working, or it's now a foreign DNA? Should I repeat that? If one takes the vaccine, will his or her DNA still be working, or will it become a foreign DNA?
Yeah, so actually, I know historically some vaccines, it's known, can enter into, be reflected into your DNA when they're implemented, but actually the SARS-CoV-2 vaccines are not the case. So when you have the vaccine injected into your body, what happens, like I said, is it binds to your cells. Your immune system learns how to recognize the vaccine, and then your immune system actually completely destroys the vaccine itself. So at that point, there is nothing left of the vaccine in your body. Once from time it's inserted to completion of the immune response, it's completely gone. And all you have left moving forward is the antibodies you've developed from the vaccine being injected. So your DNA will definitely be working moving forward.
Okay, thanks for that, Olivia. There's another one here that I think is quite interesting. There's a few, but we're trying to parse through them. Marika Kanameyer, sorry, audience, for not mentioning names earlier, but this question comes from Marika Kanameyer. She asks, is Sinopharm effective against variants? And should you mix vaccines between the first dose and the second dose?
Sorry, what was the first part of the question?
The first part was, is Sinopharm effective against variants? The Sinopharm vaccine.
Yeah, Sinopharm, yeah. And then the second part of the question?
The second part is, should you mix vaccines between the first dose and the second dose? Both very good questions, actually.
Yeah, really great question. So I think Sinopharm has been shown to be generally less effective compared to other vaccine types. And I don't know much about the production of this vaccine, but I would imagine that has to do because it's not an mRNA vaccine. So it will be mostly based off of the original genome first identified in Wuhan. So likely what has happened here, because it's also the whole genome that's involved in this vaccine, but an inactivated version of the virus, meaning it can't get you sick or anything like this. Likely what happens is your antibody learns to respond to this version of the virus that is inactivated. And then with the new variants, there might be a few too many mutations now where it makes it less effective. I think last time I saw it was maybe 20 or 30%, but that might not be the right number. And when it comes to mixing vaccines, I think in general, yes, it's fine. They were doing a couple of studies in Romania and in the UK, and I think we had some mixing in terms of as well. We had said we would stop giving AstraZeneca to people under 30 and give them Pfizer instead. But what I think the difference here really is that when you are injected with one type of vaccine versus another, your immune response that develops is slightly different. So if you can imagine that you develop a certain type of immune response, this leads to certain types of antibodies being created that recognize a certain part of the virus, right? If you are injected with a different one, this will try and recognize a slightly different part. So the antibody building, like I said, the antibody dose level might not go as high because of this.
Okay.
From the first to the second dose.
Yeah. So then that begs the question, say, for example, you mentioned the different types of vaccines, right? You mentioned the mRNA, and then there's the one where you have an inactive part of the virus, you know, the different types. Yeah. Would it make a difference if, say, for example, you get the same type of vaccine, but a different brand? So say, for example, if you start with Moderna and then get Pfizer. If I'm not mistaken, those two are the same type of vaccine,
Yeah,
right?
Exactly. They're both mRNA vaccine. To be honest, I'm not sure because I don't think I've not seen a specific study on this, but I don't think it would cause you harm per se, but I'm not sure if the antibody level would, I'm not sure if it would be a booster based on your first dose or if it would have you develop a slightly different antibody response. I mean, we also have, work we're doing now trying to look at if you're actually infected right when you're vaccinated. So sometimes this happens. We had this happening in the UK where people were attending vaccination sites to get the vaccine. And then sometimes after, because especially we were doing a mass vaccination rollout, people were coming to the vaccination sites that were sick with COVID already and then infecting other people while they were getting vaccinated. Right. So it was kind of like a double whammy. So all of a sudden your immune system is dealing with actual COVID and then also the vaccine. And, it's not really clear actually what this antibody response looks like after and what the antibody level looks like after. It seems to be relatively strong, but I think there are slightly different approaches even then. So, it's something that we need to study more. But it's a really good question.
Absolutely. Reader, thank you for that question, because I think that's something to put on the radar of scientists. It's probably already on their radar, but definitely a very good question.
Yeah, it's a really interesting aspect of the vaccination process.
Absolutely. And then we have one more from our resident epidemiologist, Pancho Mulongeni. It's quite an extensive one. So I'll just read through it. But, colleagues, so you'll probably already have the answer to this. Pancho says, when two French scientists back in 2020 discussed the global vaccine initiative for COVID-19, when they mentioned the vaccine needs to be tested in African populations, they were condemned for racism, including by the World Health Organization. How could scientists in Europe, the US, or the developed world discuss vaccines without falling into a trap of seeming patronizing to people in the developing world?
Yeah, and I think that's a really good question. And I think part of this is actually, in my opinion, stems from this issue of vaccine equity. And it's very clear to me that, at origin, of course, we had the WHO, we had the USA, we had the EU, we had the UK. Everyone had agreed, and Canada as well, where I'm from. So listen, they also did a bad thing here. We had everyone agree that, the vaccine rollout was supposed to be equitable. We were supposed to support the rollout on a global scale. And this has clearly not happened. Unfortunately, it's not really a surprise. I think this is one of, our failures in the world today is our approach to public health in general in terms of equity of access to medication and to vaccinations. And I think this is sort of the first step to approaching this problem is rectifying this and saying, actually, everyone needs to be on the same level playing field when it comes to vaccine access, particularly in the case of a pandemic on a global scale.
Absolutely.
Yeah.
Thank you for that, Olivia. There's one more that we're going to address before we come to the end of the show. This question asks, actually, there are two questions here. I'm going to read them both. Shield Corpse asks, why is it possible that those of us who got all doses of the vaccine but are suffering from this virus today, Okay, this question is a little bit difficult. Let me just parse through that. Why is it possible that those of us that got all our doses of the vaccine are suffering from the virus today? We were fine, but then the next day you have no smell, no taste, and a headache. So essentially their question is, how is it possible that somebody who has gotten both doses of their vaccine in a number of days following getting, their second or last dose still picks up the virus?
Yeah, so likely what has happened here is they were exposed, they actually caught SARS-CoV-2 when they were getting vaccinated, I would imagine. I mean, the other factor is we have to consider, the vaccines are not perfect, right? At origin, I think when they were released, we said 90%, the companies were saying, oh, they're 90% effective, which to me as an epidemiologist is very suspicious because, for example, the influenza vaccine is around 30 to 60% effective every year, and we still administer this. And this has to do with, of course, the influenza vaccine only includes 3 subtypes of influenza, and as I mentioned, there are many, many types circulating. So it's very difficult to capture an immune response that's responsive to all of the subtypes in circulation. In terms of the SARS-CoV-2 vaccine, as we get vaccinated, we still have some vaccine breakthrough or vaccine escape that occurs. But this is, as I mentioned, the more we vaccinate, the less this will happen because the less that transmission will occur in general. Because even if we say that the vaccine is 60% effective at preventing SARS-CoV-2, that still means that myself as a vaccinated person, I'm 60% less likely to become infected than someone who's not vaccinated. So already I have some protection. The protection is not perfect, but I have some. Building on that, what's really important with the vaccines now is that they seem to be 95% effective against severe disease. And that's what we're really worried about moving forward. Because as you can imagine, we live in a world where influenza circulates all the time. And it's a very similar virus, actually. But we have a certain level of immunity in the world that allows for this to circulate without causing too much damage and inundating our healthcare systems, which is really the problem with SARS-CoV-2 now. We can't handle it in our healthcare systems at the rate that it goes currently. And so what we need to do is we need to get immunity to a certain level in the world where we can handle it. We will still have SARS-CoV-2 circulating for the rest of our lives, I think. This is now an annual circulating virus. There is nothing we can do about this. But what we can do is learn to live with it. And part of this is, of course, getting vaccinated and raising the immunity in the population.
Absolutely. And a key point there is that with the vaccination, you can still pick up the virus, right? You can still pick up the virus.
Exactly.
It just reduces the chances of the symptoms being severe and reduces the chances of hospitalization, essentially.
Yeah. And it also makes it you're probably less likely to transmit as well because you won't get as sick, you won't replicate as much virus, which means you won't be transmitting as much virus out. So it's really a win-win-win for everyone.
Absolutely. Well, thank you so much, Olivia, for taking the time to talk us through some of these topics. It's very good to get a global perspective of things like a vaccination rollout plan, because like I said earlier, Namibia, we really look to, the experiences of other countries and what they've seen and what they've done to inform how we move forward with this virus. That's all we have for this evening. Olivia, thank you once again for taking the time to join us. To the audience, thank you so much for your engagement. I think it also added to the discussion and made it a lot more lively. And please keep the questions coming. That's why we have the experts on the show to answer those. I'm Arlana Shikongo, and that is all from us this evening. We hope to see you next week. Good night.